for this webinar. And this webinar is especially meant for the PG students. This is a basic topic for all of you, and whoever is going for acting examination as well as clinical point of view also. This is very much requirement for all of us. Let me share my screen.
Your audio is not proper right now.
Still not clear?
I think some earphone issue is there.
The voice is muffled. Apparently, there is something on the mic.
Okay, let me see. Is it clear now? Hello?
Yes, sir. Yes, sir.
Much better.
Okay. So a few days back, we had a patient with us admitted to our ward. I hope all my PG students know about this patient. If you look to this X-ray, it looks so funny. It's just contradicting the basic principle of amputation. So when I saw this X-ray, I thought that really the society really need our help, and our role is certainly essential for in this situation. Somebody has done amputation with very clean cut tibia and fibula cut, and he must have done some sophisticated instrument for getting a sharp cut of the tibia and fibula. That indicates it has done in a good setup, but since a simple lack of knowledge that somebody has done amputation with the fibula is 1 inch longer than the tibia, which should be opposite of this. So this indicates that our role is certainly there in the management of amputees in the society. So with this, we plan for this subject of checkout of transtibial amputees. Whenever we prescribe a prosthesis for an amputee patient, especially below knee amputee, that there are certain things we should look for. Just prescribing the prescription of a prosthesis and sending it to the PO department is not sufficient enough. We have to examine the patient from the initial point and proper evaluation and exact prescription of the prosthesis. It is the duty of our job is not end there. Again, we'll have to review the prosthesis, whether the proper prosthesis has been fitted or not, whether the patient is comfortable with this prosthesis or not. Otherwise, just you will take the prosthesis and hang at the side of the bed, and he will again continue with his old traditional movements. So our job is really great in this place. So coming to the initial part, this whole presentation is divided in 3 parts. One is clinical assessment of the amputee, and second part is the checkout of the transtibial amputee. And if time permits, we will also discuss about certain important gait deviations related to prosthetic fitting. So starting from a subjective assessment, when the patient you receive an OPD, certainly as other history taking, you have to take the mention the name just for the identification of prosthesis and to avoid any future mismatch or confusion between other subjects of prosthesis. Age is also a significant role during our clinical assessment, because your prosthetic prescription varies also depending on according to the age of the patient. If you are dealing with a pediatric patient with amputee, so you should prescribe your prosthesis is very simple and should be a durable design, must be lightweight. When you're prescribing for an adolescent, those who are very much conscious about their cosmetic part, so it must be cosmetically sound and should be a robust design so that it will last long. They can use for the heavy work purpose. And when you prescribe a prosthesis for a geriatric patient, you should prescribe simple components, lightweight, so that geriatric person can use it comfortably. Sex is also important because the females are very much conscious about the cosmesis of the prosthesis. So when you prescribe a prosthesis, it must be cosmetically good enough. Like when you prescribe a liner or a covering of and modular prosthesis, the skin cover, the covering must be equal to the skin cover of the opposite limb. And height and weight also carries some important. When the patient is heavier weight patient, you need a firm heel cushion to avoid quick plantar flexion. We'll discuss that during our checkout procedure. And in case of height, long height subject, the stability factor is also important in maintenance center of gravity in these cases. Address, though we ignore it, yes, it has also a role during your prescription. Patient has come from a far distance, you should prescribe some simple components so that it can be easily changeable and he can get the service and repair in the nearby center. And if the person is coming from, whether coming from the coastal area or from the hilly area, accordingly also you have your prescription must be changed. If it belongs to coastal area amputee, then you should prescribe the components which are non-corrosive components. And if patients belong to hilly area, so special care to be taken that when his climbs on a stiffer surface, needs some amount of dorsiflexion angle in the foot ankle assembly. Education, yes, education qualification also matters. The educated people, you will expect that they will properly care their prosthesis, and they will certainly they can use high-end prosthesis. They can maintain the prosthesis. Occupation-wise, students, school-going girls, boys, they need cosmetically sound prosthesis because they feel well. They so that they can feel well equivalent with their batchmates. Sedentary jobs or active life, sedentary jobs like ladies, a geriatric patient, your safety is concerned, low weight prosthesis you should prescribe. And if the person is very active life, young, so robust design with energy return type of prosthesis we can prescribe. Sometimes hobbies and recreational activities we take care of during component selection because you have to first quantify the K level of the patient. Accordingly, the functional component prosthetic can be recommended. You all know about the K levels in case of amputees. These are the assessment of functional levels by K codes. K1, you all know, K1 level is those amputees who are potential household ambulators. K2, functional level, potential limited community ambulators. And K3 functional level, they are community ambulators. They have a potential of variable cadence. They can move around. And K4, they are high activity users. They participate in sports and high-end activities. So one has to be sure about the functional level of the patient, and accordingly you can choose the components also. Yes, financial arrangement is also part. If the person wants any prosthesis free of course he has to go to centers where the free cost prosthesis are available. But rich patient, if you have assessed the financial capacity of the patient, you can opt high-end prosthesis, sophisticated component. Unless you know about that, you cannot suggest to the patients. So you have to assess the financial status accordingly. You can suggest, it depend upon the patient whether he will choose which way he will choose. So you can offer them also high-end prosthesis. Certain medical factors also you should take care of during your assessment procedure, like date of amputation, when the amputation was done, especially related to maturity of the stump, whether the stump is well matured or not. If the stump is not well matured, you would advise the patient how to help in maturation of stump, like starting with crepe bandage application, limb elevation, exercises program, prevent contractures. All these things you have to take care of. The patient has completed 3 months of amputation. We expect that there is not much demand. You can take over for final prosthesis. Causes of amputation also has role during prescription of prosthesis. If you are dealing with a amputee who is having peripheral vascular disease that leads to amputation, then you have to give some special care, like your prescription should include some certain socket modifications, like use of soft liners inside the socket. And if you are dealing with a patient with the cardiovascular disease, amputee patients, then your prescription should include a lightweight prosthesis to minimize the energy expenditure. Level of amputation also decides that what type of socket will prescribe, especially for below-knee amputees, short stump, very short stump, or a adequate length stump. So if you take the length of the stump, a stump will call adequate ideal length stump when it is 2/3 of the stump length is 2/3 of the original bone. Short stump normally within 33% of the sound side length. These cases they have certain instability, like mediolateral instability. So they need stability, mediolateral stability. especially for the transtibial amputees, you need to prescribe special sockets like patellar tendon being supracondylar or patellar tendon being supracondylar, suprapatellar. But medium stomp, they have stomp length around 67% of the sound side. Then you can prescribe a standard component of PTP prosthesis. If you are dealing with a long stomp, around 60, more than 70% of the sound side length, relatively that is a longer stomp, it has less advantage for below knee. But for socket, you have to arrange special space management has to be arranged. Because many times the end of the stomp will hit to the shank area, so distal part of the socket. So you have to have arrange special designs. So you may sometimes have to make a window to accommodate the distal end of the stomp, like in SIMS prosthesis. So in a long below knee SIMS amputation, or you need exoskeletal designs, because as I said that you have to put some window, something like that, to negotiate the end of the stomach, especially when you accommodate like a SIMS type amputation. Now coming to the objective assessment, certain that is also important. You have to check the joint range of motion, strength of the muscles around the proximal joint of the stomp. That this provides a parameter to select components according to flexibility and endurance of the joint, and identification of the contractures. The patient having already contracture more than 10 degree or 20 degrees, so you may need to go for a exoskeletal prosthesis, or you have to correct the deformity and go for a endoskeletal prosthesis. Especially when there is a loss of proprioception, that needs a total contact socket, or you have to be conscious about those patients. Many times you don't check that, we just check for the sensory motor part, but proprioception also a part to evaluate during the stomp assessment. You all know about ideal stomp. We always look for ideal stomp for fitting of a prosthesis. Of course, nowadays all types of modifications are possible with use of different materials for preparing socket, using 3D principles for preparing, taking the cost of the socket. So nowadays a lot of advantages have come up, but still we try to look for an ideal stomp, so that the ideal prosthesis can be fitted and with a minimal cost and energy efficient, and the patient can do all his activities with this ideal stomp. Especially the ideal length, we all know it is 2/3 of the original bone length, and preferably it is a conical stomp for the below knee or above knee. There should not be any edema, there should not be any phantom sensation, should be free of inflammation and infection, there should be healthy skin, it should be neuroma free, no fixed contracture of the proximal joint, there should not be any bone growth which is impinging to the distal part of the socket. The muscle power of the proximal joint should be adequate enough. There should not be any instability to the proximal joint, and overall it should be painless limb. These are the basic criteria of the ideal stomp for fitment of the ideal prosthesis. Bulbous stomp sometimes causes problems fitting, but it can be managed by using a total contact type of socket. And if there is a presence of scar or tissue or skin grafts, you have to give adequate relieving areas in the socket. You have to advise in your socket prescription that the scar area, the sensitive area, the bony prominence, which part of the stomp, and accordingly the relief can be given, a room can be given in the socket. Neuroma and trigger points. Neuroma, if you have facility, you can excise the neuroma. A small neuroma is not bothersome. You can also modify the socket and accommodate that part also. And when there is a poor proprioception or the skin is very much fragile, they are a well-controlled socket with the silicone or nylon liner is required to avoid skin irritations, especially when you are dealing with a fragile skin. Now, coming to the prosthetic factors also need to be assessed. Socket type very often for the transtibial. Today we are discussing a transtibial amputee. The common socket we use in common clinical practice are PTV socket, and there are certain modification to the PTV sockets like supracondylar or suprapatellar, depending upon the length of the stump. It is very short, then suprapatellar and supracondylar is the ideal one. Besides that, if you have facility, then other types of sockets can be used, suction socket or hydrostatic socket, or total surface bearing socket. Other sockets are there, but for a common purpose, very often we use this PTV, PTV-SC or PTV-SC-SP sockets. The next part of a prosthesis suspension system. Very different type of suspension systems are there. Why I'm discussing these things? Because these things are also required during your checkout procedure. So these three components: socket part, suspension part, and foot and ankle part. These are three important components. Besides the shank portion or pylon portion is not almost fixed one, but these three things: socket, suspension, and foot and ankle assembly. These three components needs modifications depending upon the situation, depending upon the stump, depending upon the requirement of the patient. So suspension system, common use, we are using this cup suspension system, supracondylar cup suspension system. Though it is called supracondylar, actually it is not placed at the condylar level. The reef button is placed at the upper end of this patella rather than condylar area. Some outside hinges and thigh corsets are required when we are dealing with a geriatric person, poor proprioception, instability is there, knee instability is there. You need to extend the knee support to the thigh by putting a hinge with thigh corset and thigh. These hinges must be correspond to the epicondyle of the femur, not to the joint line. And then waist belt is very elderly person, very short stump elderly person. Waist belt, of course, not so common use now because of different suspension, advanced suspension systems have come up now. Waist belt is rarely used. Supracondylar, suprapatellar already mentioned for a short stump, below knee stump. Thigh slip, suction suspension, silicone slip pin and shuttle lock suspension, and vacuum assisted socket suspension. These are different options for you. The system where you are working, what are the facilities available with you, and how much the patient can afford also decides the type of suspension system. Then third important component is the foot and ankle assembly. And the selection criteria for deciding a foot and ankle assembly are body weight. As I said, high body weight, heavy body weight, with a stiff bumper or a stiff heel, then a residual limb, then other comorbidities like diabetic and other comorbidities, environmental exposure and durability. Of course, the cost is also important. Accordingly, we use different types of foot and ankle assembly. Out of all these, very common is the solid ankle cushion heel or SAS foot design. Other than that are the single axis foot with a bumper allowing some plantar flexion, dorsiflexion movements, multi-axial foot, flexible keel foot, microprocessor foot, running blade or dynamic elastic response foot. These are all high-end designs used for high-end prosthesis, especially athletes, and some imported companies using this foot and ankle assembly in their prosthesis. But however, it can be fitted for any patient depending upon the need of the patient, requirement of the patient, and afford capacity of the patient, and the setup where the things are available. This completes the basic components of the transtibial prosthesis. Now we'll discuss about the checkout of transtibial prosthesis. So what do you mean by checkout? Checkout is a systemic examination of the amputee and their prosthesis to determine whether the accepted standard have been met or not. Okay, whatever prescription you have prescribed, whether the standard prosthesis has been fitted as per your prescription or not. If not, then corrective action need to be taken to rectify the deficiencies. So you prescribe the prosthesis, the prosthetic orthotic professional, they prepared the prosthesis. You have to check whether the prosthesis is properly prepared as per your instruction or not. And if not, what are the problems with that prosthesis and how can it be corrected further so that you can improve the quality of the gait pattern of the amputee patient. So this is our responsibility to see whether the prosthesis, it's not our responsibility, doesn't end over just prescribing prosthesis. So we'll have to check it out. Many times in our setup also, many times with busy work schedule, we hardly go in detail, but in practical, for academic point of view, one should go through step-by-step assessment of the transtibial prosthesis. So what are the points to be considered during a checkout? Comfort of the using the prosthesis, stability of the prosthesis, whether alignment is proper or not, whether the appearance is acceptable to the patient or not. So all these factors should be taken care of during the checkout. It is not only technical component, certain psychological component also you should look for during evaluating the or checkout assessment of the transtibial prosthesis. There are two types of checkout: initial checkout and final checkout. Initial checkout means the prosthesis provided is whether the prosthesis provided is as per your prescription criteria or not. That's the first part. Then to evaluate the biomechanical adequacy, efficiency, and design of the prosthesis. So as per your prescription, whether it is prescribed or not, and whether it is the biomechanically acceptable design or not. Is there any biomechanical error which leads to a abnormal energy consuming gait or harming to the patient? That has to be evaluated. So in final checkout, whatever things you have detected in initial checkout, whether this biomechanical adequacy of the device is reviewed, corrected or not, evaluation of the extent and effectiveness of the patient's use of prosthesis, you ask for the gait training, how the patient is walking, if the patient is walking with the proper gait or not, and also physical and psychological status of the amputee need to be assessed in the final checkout. So if you take the checkout process as a whole, I can divide into 5 components. General checkout as a whole, then checkout with amputee standing, checkout with amputee sitting, checkout with amputee walking, and checkout with prosthesis of taking out the after taking out the prosthesis. All these parts step by step one should evaluate. In general part, whether the prosthesis prescribed is taking the patient taking the prosthesis as per your prescription or not. If the recheck have previous recommendation has been accomplished or not, whatever recommendation you have suggested in initial checkout, whether that has been corrected or not, then how the patient is doing donning and doffing of the prosthesis, whether is it comfortably wearing the prosthesis and taking out of the prosthesis or not. Many times you see the patient struggle with fitting of the prosthesis. So unless he is not able to fit it comfortably, how can he will use it? So it must be easy donning and easy doffing. Now the next part is checking of the transtibial prosthesis with amputee in standing position. The first question is the amputee comfortable with standing with midline of the heel not more than 6 inches. So basic criteria say how is standing. What is the difference between the normal foot and the prosthetic foot? Whether it is there any associated discomfort or he is comfortable with the prosthesis. Okay, so an amputee who wear a prosthesis for the first time will notice some amount of discomfort or pressure in the stump. However, if the pressure should be within the tolerable limit, then counseling the factor. This first time you are using the prosthesis, there always will be some discomfort. You go on gait training. After a few days, certainly this discomfort will go away. That is the initial part. Now, if the discomfort persists, then you have to look for what is happening. Is there any specific pressure? Very often, if you take out the prosthesis, if you find the socks marks, the mark of the socks over the stump, impressions, that indicates the area where the redness is there, the deep impression of the socks of the stump is there, that those are the areas where the pressure is building up. So you ask the patient, is he feeling the pressure in that area? If that is the fact, then you have to suggest your prosthesis for further modification. Then second is this anteroposterior alignment of the prosthesis. First instruct the patient to stand in erect posture, then fix the anterior portion of the heel of the foot. In this picture you can see from the lateral side, you will see whether the sole of the foot is flat on the ground or not. Whether this ball and heel is on the flat on the ground or not. Okay, and second part is that the amputee should maintain knee stability with minimum muscular effort and should not feel that his knee is being forced backward. So if there is any abnormality in the socket fitting, whether excessive knee flexion, socket flexion, or flexion contraction of the stump, so that creates some abnormality. The patient will voluntarily contract his quadriceps for standing purpose, for normal standing purpose. That has to be checked out also. Okay, so this is one component of anteroposterior alignment. The foot must be well seated on the ground. Then medial-lateral alignment of the prosthesis. If it is a suprapatellar, supracondylar, it's fine. You can feel the space between the supracondylar area and the elevations on medial and lateral side. If you are dealing with a classical transtibial prosthesis also, you have to check the medial and lateral margin of the socket. Look at the saw to determine whether both the outer and inner border of the saw are contacting with your floor or not. If there is any tilting of the socket, normally some amount of varus alignment is there in normal prosthesis. If there is excessive varus alignment in the socket, then you will have a changes in the sitting of the foot on the floor. There you will not find that both the borders of border of the foot are on the ground. So one side will be tilted off. Okay, so you should check both inner and outer border of this shoe. Okay, then examine the medial and lateral margins of the socket, upper margin socket. If there is a tilting, one side you will get a impingement of the skin, other side you will get a gap. That indicates that there is some medial lateral malalignment need to be corrected. Length of the prosthesis, one should check it on weight bearing position, because if there is a piston knee plate lax in the suspension system, so each time the limb goes to swing pace, the prosthesis will come down. It appears like a longer prosthesis, but it's not like that. It should be measured in a weight bearing position. Similarly, as I said, if there is a piston action, ask the amputee to lift the prosthesis side without flexing the knee in standing position. Okay, then how do you know that piston action is there? So the socket is loose, suspension is poor. How do you that creates a piston action, and that can be evaluated by marking the stump socket position at the level of posterior brim. Mark the posterior brim, ask the patient to lift the limb by hip hiking, see whether that posterior brim is coming down or remaining in position. The prosthesis should not slip more than 1/4 inch from your demarcated line. That indicates there is a socket loosening or there may be a poor suspension system. Then adequate length if anterior, medial and lateral walls are adequate or not. Check the adequate height of the socket wall. That is essential for comfort and stability. Now coming to medial and lateral wall contact. Check the improper shape of the socket wall. It will result in inadequate suspension and stability. So you have to check whether the medial and lateral walls in proper alignment or not. Do the uprights conform to the flares above the epicondyle? This is meant for only those cases required, say thigh corset, elderly person, small kid, where it are very short stump, where you need a thigh corset. You need to have a hinge, whether the hinge is corresponding to the desired level or not. The close fit between the uprights and the thigh ensures great stability and suspension and less bulky. So it should not be wide apart. Be close to the surface. How much close? It should be 1/8 to 1/4 close to the epicondyle. So this is made for only those transtibial prostheses where you need a thigh corset only. It's not meant for the classical PTB prosthesis with the cup suspension. For example, this one, thigh corset should be fit properly with adequate provision for adjusting the correct tension. There should not be a pressure at the distal margin of the cuff and pressure at the loose at the proximal margin of the corset. Now, check the prosthesis in patient in sitting position. This is a very important thing. We cannot ignore that. Especially check over this popliteal area and see whether the patient can sit comfortably with minimal bunching of the soft tissue in the popliteal region when the knee is flexed to 90 degrees. Very often we ignore this. We just ask the patient to walk, but please look to this popliteal area by asking the patient to sit on a chair or sit at table. See, is there any hamstring roll? There should be a hamstring channel over here for relieving this hamstrings tendons. You know, the hamstrings are also the pressure relieving area. Of course, the posterior whole popliteal area is the weight bearing surface for a PTP socket, but the hamstring rolls must be free enough. These are pressure sensitive areas. So you have to look for, is there any hamstring roll bunching of the soft tissue while knee is in flexion? That indicates maybe the posterior brim of the socket is high enough and the hamstring channels are not properly prepared. Next, is the amputee able to kneel satisfactorily? Of course, there are some limitations to this. If you are dealing with a PTS or PTSB design, so kneeling is difficult, but for a classical transtibial PTB prosthesis, one can comfortably go for kneeling. But again, when there is a suspension problem also, that also prevents kneeling. The amputee using wearing prosthesis with the supracondylar, suprapatellar suspension may not be able to kneel long time because of this prominent extension of the prosthesis up to upper margin extension up to supracondylar area. That creates problem. And moreover, the suprapatellar margin is just above the patellar upper end of the patella. That also creates problem during kneeling. Now, the third part is checking with amputee walking. Is the patient performance in level walking satisfactory? An amputee wearing a PTB prosthesis with a cup suspension strap may exhibit a slight lateral thrust of the proximal brim of the prosthesis. You all know a normal PTB prosthesis is aligned with a little bit varus position. That to simulates a normal anatomical locomotion. And the second thing also, by putting little bit varus position, a varus thrust will be applied on the lateral side so that the weight bearing surface will conform to medial flare and lateral surface of the stump, of course not over the tip of the fibula or the head of the fibula. So this lateral varus thrust is because of this deliberate varus alignment of the socket position. But this varus alignment must not be too much so that it will create discomfort and instability in the lateral end of the stump. Now, does the amputee go up and down, inclines and stairs satisfactorily? The amputee who has not previously owned prosthesis may initially find difficulties for stair climbing. This happened for everybody if he is a first time user. Okay, but you should look for length of the stump, age, general physical condition during evaluating the procedure, and also adequacy of the suspension system. Yes, many times beside the socket, of course, the suspension system is a very small structure. Sometimes that creates discomfort during the working, especially when the socket, the suspension system is placed more anteriorly or more posteriorly. Check the position of the cup suspension strap. It should maintain over patella as the amputee works. If the buttons are unduly anterior, the cup suspension drops when the knee is extended. Again, when it is flexed, it will place over the suprapatellar area. So it should be properly placed so that it will be in place both in flexion and in extension. Now, the last part is, does the prosthesis function quietly? Okay, many times you will find some noise during each step of working. Okay, many times these noises comes from foot and ankle assembly or from the suspension strap. These are the two potential points which creates noise during working. And sometimes some hissing noises also comes. That's because of the certain cases there are some piston effect during the working, especially first time users when the inadequate socks are used. There is a relative gap between the socks and the stump and socket interface. So each time patient bears weight, the air comes out. Again, when swing phase it comes down, the air goes in. So there creates some hissing noise. It's because the air enter and air escapes to the socket while the amputee works. And it's because of the piston, sometimes because of pistoning action. And the cosmetic part is the last. The size, contour, color of the prosthesis is as per the sound side or not. That is also a part one should look for. The last part is check out of the prosthesis with prosthesis off. Amputee stump free, must be free from abrasion, discoloration, and excessive perspiration. Immediately after prosthesis is removed. Then, as the patient remove out the prosthesis, check the stump. Is there any features of abrasion, any redness, any pathology, or any excessive perspiration? Okay, that should look for. Remove the prosthesis, inspect the stump. If there is any discoloration present, check the areas of discoloration if it is associated with pain, discomfort, or sensory deficit. As I was telling earlier, even stump, the socks marking also sometimes helps in deciding that what are the areas where the excessive pressures are happening. Inspect the stump to see if the weight is being borne in the indicated areas or not. As I said, we all know about the weight bearing and weight relieving areas of the PTB prosthesis or transtibial prosthesis, patellar tendon, medial tibial flare, and lateral and posterior aspect of the stump, especially bigger area in the posterior aspect, and the weight relieving areas, especially the head of the fibula, neck of the fibula, tip of the fibula, lateral flare. So these areas must be hamstring rod. These areas must be relieved from pressure. Adequate height of posterior wall of the socket. High posterior socket wall minimizes popliteal load, stabilizes the stump in socket, and distributes pressure over the wider areas. But at the same times, it should not restrict his amputee to sit. That is major hindrance causing a problem in sitting. In any case, the posterior wall should never be lower than the patellar tendon level also. Well, that is a counter force which act against that the patellar tendon gears over the crease of this PTB socket. The last part is there the workmanship is satisfactory or not? Is there any prominent repeat, any firm margin, or any rough area, or any rough plastic lamination is proper or not? So anyway, there is any problems in the rivets. Is it harming to the patient? That is the our lookout to see whether this workmanship is satisfactory or not. And finally, you have to take the opinion of the amputee whether he is satisfied with this processes or not. If he is not satisfied, what are the reasons? And again, you can go back to the the problems associated with the socket or any other part of the prosthesis. Hopefully we have time. We can go for the important component, the gate deviation related to the storm problem. Initially, you have checked out the gross errors in the socket. Then you have to look for gate deviations. From that, retrospectively, you can analyze. Especially this decides the malalignment of the different component of the prosthesis. So this is also important. So transtibial gate deviation, there are a list of gate deviations occurs while amputee working using the prosthesis, and we have to correlate with the normal gait cycle. But how it differ from the normal gait cycle? This is all different phases of the gait cycle: initial contact, foot flat or loading response, mid stance, heel up, toe off, then pre-swing, then swing phase. So we are concerned about this weight bearing position, especially on the gait cycle, that is stance phase. We'll discuss the swing phase also, but basically the malalignments are related to the stance phase. So as an overview, we have to look for deviation in the heel strike and mid stance. That includes excessive flexion and insufficient flexion of the knee. Okay, at mid stance we have to look for, is there any excessive lateral thrust? Lateral thrust is normal. If it is excessive lateral thrust, then between mid stance to toe off, we'll look for early knee flexion or delayed knee flexion. And during the swing phase, we'll look for what type of whip gait. If it is there in a whip gait? If it is a whip gait, it is in sagittal plane or in frontal plane. What is about the foot clearance during the swing phase? So these are the things we'll touch during our discussion. Now, the initial part of the stance phase between heel strike to mid stance. The first thing happen here is excessive knee flexion. It happens when the prosthetic foot is set too much in dorsiflexion. Too much in dorsiflexion. Okay, so in contrary, if you look to that, our normal prosthetic orthotic prescription is somebody is having a hyperextension. You want to do some amount of knee flexion, you prescribe a AFO with a certain amount of dorsiflexion. The same thing happened here in the prosthesis also. Okay, if the foot is by mistake or malaligned to a little bit more dorsiflexion, that will lead to a excessive knee flexion. Okay, just imagine heel strike, when somebody will foot flat, okay, it will not go to the normal foot flat position and knee will go anterior, leading to a knee flexion. Normal socket displays excessive anterior tilt up if it is more than 5 degrees. Normal socket is 5 degrees anterior tilted. Why? Because we want a ground reaction force should be more vertical against the patellar tendon. So we need that a weight bearing, for a effective weight bearing, the socket should be 5 degrees anteriorly tilted. But if it is beyond that, more than 5 degrees, that creates excessive knee flexion. So one is excessive dorsiflexion of the foot, or if there is excessive anterior tilting of the socket more than 5 degrees. Okay. Next, when the plantar flexion foot is restricted by an excessive stiff heel or plantar flexion bumper. For a normal person, a normal gait, heel strike, it should be plantar flexion. Think about a SAS foot. For a SAS foot, the heel cushion should be adequate enough to have a controlled plantar flexion, simulated plantar flexion. There is no movement, solid ankle cushion heel, solid foot, foot and ankle ascent, but that bumper, the soft bumper of the heel, that helps in simulated plantar flexion. Okay, if that softness is not there, it's very hard enough, then there will be sudden plantar flexion. Okay, so that leads also, secondary leads to knee flexion. It also does not absorb the impact of the heel striking flow, thus result in abrupt and excessive knee flexion. Okay, so hard, stiff heel cushion in SAS foot or a hard bumper used in a uniaxial foot design. Okay, so these are the causes of excessive knee flexion. Now, what happens if there is excessive anterior displacement of socket over the foot? Okay, please look to this picture. This is a normal picture, normal alignment. Okay, this is the line of force of body weight. You can say CG also along the socket. And this is the ground reaction force. So this weight or CG and ground reaction force should be balanced with each other to maintain the normal gait pattern. If the socket displaces anteriorly, so the gap between this ground reaction force and the CG is increasing, gradually increasing as the socket goes anterior. What happens when the socket plays forward related to the posterior foot? Increases the distance between the action of the force transmitted through the socket and the ground reaction force. That results a force couple. And that force couple, you can imagine here, when the force couple generate here, so there will be always an anterior tilt, a rotation of the socket. Okay, the socket will move, the more it moves anteriorly, there will be a socket rotation. Okay, that is also another cause of excessive knee flexion. If the patient is already having a flexion contracture or posterior misplacement of the suspension, posterior misplacement of the suspension also prevent full extension of the knee. Okay, that creates incomplete extension of the knee, behaves like a excessive flexion at the knee joint. Okay, so position of the placement of suspension system also creates a excessive knee flexion. The second part is, one is excessive knee flexion, second is insufficient knee flexion. Or you can do the knee remain in extended position. Okay, the transtibial amputee may work with absent or insufficient knee flexion on amputated side for several reasons. What are the reasons? These things should be, we will expect these things. On heel strike, then when the foot goes to initial stance or foot flat stage, there should be 15 degree of knee flexion here. Knee flexion is allowed here 15 degree. When the foot goes to mid stance, then it becomes, knee became neutral. When the foot becomes toe up or heel up or terminal stance, again the knee will be completely extended. So in the phase of gait cycle, the complete knee extension occurs at the mid stance onwards. Before that, we need amount of knee flexion. So we need some amount of, it should not be excess one, but it should not be less knee flexion also. That also happens like this. In foot flat stage, there should be some amount of knee flexion. Say around 15 knee flexion is required. So what are the causes of insufficient knee flexion? Excessive plantar flexion of the foot. We all know that when we want a knee extension, always we put the foot in plantar flexion. Some amount of equinus is given. Think about the FRO also. The same principle. In the FRO, the ankle is placed in a little bit plantar flexion, which creates a posterior thrust. The resultant force pushes the knee backward. The same thing happened here also. If the foot is by mistake placed little bit plantar flex position, there is always a posterior thrust and there will be insufficient knee extension. Okay, so if the prosthetic foot is in an attitude of plantar flexion, foot flat will occur prematurely and prevents normal knee flexion after the heel strike. So this is the problem with this plantar flexion of the foot. Then excessive soft heel cushion. So we have discussed, if there is a hard heel, then there is abrupt flexion. When there is excessive soft heel, the reverse will occur. Okay, so knee will begin to flex only after the heel cushion has been completely compressed in a normal SAS foot. Okay, when there is excessively soft heel, that will allow the prosthetic foot to plantar flex too rapidly with a slap on the floor. With a slap on the floor. Okay, similar like a flat foot. If you the heel is put there, suddenly the foot will drop. flat on the floor, where there is no dorsiflexion control. Here, because it is very soft heel, once heel strike is there, suddenly the foot will flat on the floor. This abrupt contact of the foot with the floor will tend to decrease the range of knee flexion. Okay, so knee will go to insufficient knee flexion or go towards extension. This part will be affected from initial contact. Here, if the bumper or the cushion heel is very much soft, there will be immediate drop of the foot, and the way it should go from gradual heel strike to foot flat, that will not happen. This abrupt foot flat leading to insufficient of the knee flexion. And the just opposite of the initial abrupt flexion related to socket placement, here is just opposite. The socket is placed more posteriorly. There it was more anteriorly. The force couple was in anterior aspect. Now the force couple is now in the posterior aspect. The decrease in the force couple to rotate the socket in flexion. The normal rotation the knees should happen during the mid stance or full foot flat stage. That will not happen because the socket has gone posteriorly. Okay, so rather it may result in a hyperextension socket. Okay, so this is a factor. If there is insufficient knee flexion or the knee remain in extended position, then the factor may be the socket placement. It may probably the socket is placed more posteriorly. Then anterior distal discomfort with the knee in flexion. Yes, there will be anterior distal discomfort means the patient will feel discomfort at the terminal end of the stump, especially anterior part. That means the stump is the anterior part of the distal part of the stump is hinging against the anterior wall of the socket. Supporting body weight with knee in flex attitude is possible only if the knee extensors act with sufficient force to restrain the flexion movement. If you analyze the socket position of a normal PTB socket, as I said, it is 5 degrees anteriorly inclined. Up to that, it is fine. If it is there, more inclination is there. To maintain the stability of the knee, the quadricep has to work vigorously. Each step, quadricep has to act actively to maintain that 5 degree flexion or 10 degree flexion. Unless quadricep is not acting, knee will buckle it. Okay, so during that process, the quadricep is contracting to maintain the knee flexion. So indirectly, what will happen? The quadricep is trying to extend the knee. That will impede the anterior surface of the stump to the anterior wall of the inner surface anterior wall of the socket, and that will create always a discomfort. This is very often seen in case of long stump. To avoid that, the amputees try to create all sort of types of things to avoid that thing. He will adjust himself. Okay. So he to avoid this type of pain, the amputee may work so that the forces acting the knee tend to extend. He will try to other way to extend the knee rather than to flex that joint. Okay. So what are the things? This trick movement, say the amputee normally they do by shortening the prosthetic step. That side step will be reduced. Okay, the stance phase will be reduced. That's like antalgia get. So that side the stance phase will be reduced. Okay, then digging the heel into the ground by means of increasing the hip extensor activity. He will try to prevent that by increasing a hip extensor activity, adopting a forward lurch of the head and the shoulder. So basically, he is trying to prevent the compression of his anterior stump against the socket. He will try to bend forward. Or sometimes all these three combinations they use to prevent this discomfort at the end of the stump. Now, if the quadricep muscle is weak, okay, the quadricep is not strong enough to control the knee at the heel strike, the amputee may compensate in the same way. as we discussed earlier in the previous slide. Okay, and there will be anterolateral discomfort. These gait maneuvers tend to force the knee into extension and thereby less eliminate the need for quadriceps activity. So basically, it's a trick movement by the amputees. They try to reduce the activity of the quadricep contracture by using other way, like using hip extension or bending forwards, like that. What is the habit of the patient also one should look for? Amputee who have established a pattern of walking with knee held in extension after heel strike may continue to walk with the extended knee. So that habit has to change. Patient has to explain that this is the reason of the discomfort at the stump. So you change this habit. You change, try to walk for straight. Don't bend forward. Don't bend your neck forwards. Don't try to have a compensatory movement. If you have any problem, we'll try to modify this, okay, rather than you change your habit for a comfortable movement. So this is about the early stance. Now it is the mid stance. Mid stance when the weight is completely beyond on the socket. Weight is borne completely over the socket. So what are the problems we expect? Excessive lateral thrust on the prosthesis. Yes, as I said, normal thrust is always, alignment is a varus thrust is always there. There is some inclination laterally in a normal socket. Okay, but that should not be excess amount. If there is excess amount of varus thrust, you will find that there will be a impingement of this medial margin of the socket on the medially, and you will get a clear gap on the lateral side. Okay, and this when it becomes excessive, that will leading to discomfort or pain. Then excessive medial placement of the prosthetic foot. Normally foot is medial placed to get a varus thrust. It's normal. Okay, but when the medial placement is excessive, if the supporting limb is too far medial to the line of the action of the force transmitted through the socket, a force couple is created that tends to rotate the socket around the stump. Okay, in almost all instances, this thrust can be minimized or eliminated by outsetting the prosthetic foot slightly. As I said, for a normal alignment also, the foot is placed a little bit medially to get a varus thrust. Okay, if it is excessively medial, this varus thrust will be prominent. You can get it by examining the margin, superior margin in the socket. And in that situation, you have to little bit decrease the medial shift of the, advised to decrease the medial shift of the prosthetic foot to bring back towards a normal alignment. Then abducted socket. This is a error in fabrication of the socket procedure in socket. If socket has been set in excessive abduction position. Think about this. Suppose this is a left socket, is in abducted position. Okay, no, this is right socket placed in abducted position. So what will happen? That the beam is tilted medially, simulating genu valgum. If the stump is abducted, at the knee point it will be genu valgum. Okay. So and in genu valgum position, it is placed on the vertically position on the residual line. The distal end of the prosthesis shift medially. Of course, when it is in a valgus position, the distal end of the stump is more medially. Okay. So in the patients, the weight shifts at the lateral body of the foot. In abducted stump, just imagine, and in you also, if you keep your limb in abducted position where the weight bearing is passing, this in turn increases the lateral thrust of the socket beam. But still, this is not encourageable. If the patient is already having existed foot abduction or valgus deformity, they are that condition different. You have to modify accordingly. But in a normal valgus or varus alignment of the knee, this abduction socket is not encouraged. Now the next page is mid stance to toe off. Mid stance to toe off. Here the mid stance stage to the toe off or heel up, then toe up stage. Just prior to heel up during the normal gait, the knee is extended. Thereafter, the knee motion became reversal. As I said, this is the contest stage, heel up stage where the knee goes to full extension. Even in mid-stand stage also, the knee is in neutral. But in heel up stage, it is going to full extension, going towards hyperextension angle if there is a laxity is there. Okay, and when the limb goes to pre-swing stage, the whole procedure became reverses. That means flexion starts. This knee flexion coincides with the passing of the center of gravity over the metatarsophalangeal joints. Now the question comes out of our prosthetic part that we have a keel and we have a keel and the keel, the end of the keel correspond to the metatarsophalangeal joint, and the center of gravity must pass across that to maintain this cycle of motion from knee extension to knee flexion. Okay, so this knee flexion coincides with the passing the center of gravity over the metatarsophalangeal joints. If the body weight is carried over the joints too soon, that results a lack of anterior support that would allow a premature knee flexion or drop off. Okay, if there is a very fast transition of the center of gravity across the ball and this metatarsophalangeal joint, there will be abrupt knee flexion, premature knee flexion. The same thing can also possible by excessive anterior displacement. My friends, if you remember the excessive anterior flexion, the same thing here is also happening. The foot and ankle assembly also, if you consider that also, that time was the socket was the issue. Now here the foot and ankle also is the issue here. With the shifting of the socket more anteriorly, the line of force is coming more close towards the metatarsophalangeal joint or end of the keel. Okay, so there that will allow a flexion very quickly. There will be early flexion of the knee, which is not advisable. That creates instability. Then subdorsiflexion bumper. If that time it was hard, it is subdorsiflexion bumper. These conditions also minimizes that the distance that the body weight must move forward before anterior support is lost. The shorter the distance, the earlier and more abrupt will the knee flexion. As I said, when the line of force of the weight, or you can say center of gravity, is very close to the metatarsophalangeal joint, where the foot propulsion, the rotation occurs at that point, as it quickly passes the metatarsophalangeal joint, quickly also that leads to knee flexion. We want a extension to gradual flexion. We don't want an abrupt flexion. That leads to a drop off. The just opposite is the delayed knee flexion. The knee joint will remain in extension during the latter part of the stance, like towards the toe of stage and pre-swing stage, where knee is supposed to go towards knee flexion. Okay, and the ankle will feel as if that ankle is working on a uphill. You feel the uphill sensation since its center of gravity would carry it off and over a extended knee. It should be a flex knee. So what are the causes of delayed knee flexion? Same as in case of socket. Here also same thing, if the socket is placed more posterior. Excessive posterior displacement of the socket over the foot, anterior displacement of the toe brake or the keel, or excessive plantar flexion of the foot, or excessive posterior tilt of the socket. All these are already we have discussed during the socket part, evaluation of the socket. So excessive plantar flexion of the foot, that also causes either extension or delayed flexion, or excessive posterior tilt of the socket also causes delayed knee flexion or extension, hard dorsiflexion bumper. Okay, these are just repetition when we are dealing with the correlating with the foot component. Now the last component is during the swing phase. During the initial swing, the heel of the foot should accelerate smoothly. Okay, if it is held, that leads to a whip gait. Whip gait means thus the limb is thrown proximally or anteriorly with like a whip. Okay, so this whip may be a sagittal plane whip or it can be a mediolateral whip. Okay, so this is mainly due to cup suspension which is not aligned properly, or a prosthetic socket which has a mediolateral instability. In mediolateral instability, you will get a mediolateral whip. If there is a suspension problem, you will get a sagittal plane whip. And during mid swing, the prosthesis should not touch to the ground. There should not have a hip hike to clear the foot from the ground. What are the reasons why there will be hip hike to clear the ground? When the prosthesis is too long, the length of the prosthesis is normal, more than the normal length. When the suspension is too loose, during mid swing stage, the prosthesis will go down and it will hit to the floor. To clear that, the patient will try to do hip hike to clear the ground, or the knee flexion may be limited. From there is strong problem, or there is a muscle weakness, or lack of gait training. So these are the things which can leads to a improper ground clearance. One should look for that. This is a problem in the mid swing phase. Then for overall, a physiatrist must evaluate whether the amputee patient with prosthesis is having an energy efficient gait by different methods of assessment of energy efficiency of the things. Then whether the patient is following respiratory question is very simple thing also. And then normal pattern, whether the gait is near normal or not. Then the amputee patient should have a lesser degree of prosthetic discomfort, and after that also overall the proper counseling is required, especially those who are first time users. They face a lot of problems. You might be thinking that there is alignment problem, but the first time user, because of poor gait training, or you try to shortcut the gait training because of the cost factor, there also patient will have abnormal gait, and that leads to rejection of the prosthesis. So that's why counseling is more important. Call the patient in frequent interval, see whether the problems are sorted out or not. If still proceeding, have a second look to the alignment of the prosthesis for confirming the prosthesis to the patient. Thank you very much. I hope I have covered most of the things about the transtibial checkout of the prosthesis. Using sir is still with us. He will supplement any lacuna in this presentation. If I have missed something, he can add to that. And questions also, students can ask questions also.
I think you have covered really very well. And a number of things are so complex to understand that can only be learned by the students by
demonstration,
looking at the checkout.
Right, sir.
I
Demonstration is very
remember
much
my
essential.
times in the clinic when we used to do the checkout. It used to happen so fast that we couldn't really make it out. And in case somebody says gait analysis for the amputees, you find the prosthetic factors or the stump factors or the training factors. So you have to discern it. It used to be very, very complex. So we started doing one by one in the clinic, keeping all this in background and repeatedly looking at the gait deviations, which you have very nicely presented. You can't cram up everything in such a short period.
Sir, we are also facing the same problem in our institute. We cannot actually, though theoretically discuss so much things, we must learn those things, but in busy clinical, in OPD practice, so we cannot cover all the points during the assessment also. But so a student must know.
That, yeah, my point was that you know so much. I mean, there are so many deviations, but practically, unless you apply those deviations, you can't remember.
Exactly,
so it's
sir.
very important to check that.
Sir. My request for all participants, this will be available in the YouTube also. Have this presentation with you. Whenever you have a patient for checkout, please go through this presentation. You go one by one, see whether what are the criteria you are meeting, what are the things you are looking in this processes. I hope this presentation will be helpful for the students in future also.
Excuse me, sir.
Yes.
Sir, am I audible, sir?
Yes, yes, you are audible.
Sir, some question is there in chat box. Kindly,
Yes,
sir.
yes. Let me see those questions. What are the questions? Can you pick up those questions and ask here, Saurabh?
Sir. Sir, the first question is that how is this classification done in bilateral amputee, sir?
Which classification for K classification?
Sir,
Sir,
at first,
the first
uh,
classification where the stump length was compared with the normal side. So how it is done in case of a bilateral amputee?
You have to take the length of your upper limb also, bilateral upper limb also. You can expect the what would be the limb length outside. And moreover, the bilateral amputee's length is not that much of concern because you are going to fit on the both the side prosthesis. Okay, you can adjust the height as per the requirement. However, there is a proportionate between the upper limb and lower limb and along with the trunk. Accordingly, you can decide. And in case of unilateral amputee, length is a major concern. You have to correlate with the normal side. If bilateral amputee, since both sides are lost, so you can adjust the height on the either side. The height adjustment is with you. So it will not be a big issue.
thank you, sir. Sir, one more question is there from Divakar, sir. Sir was telling that his patient is overweight and complaining of pain, overpressure, tolerant areas on prolonged standing and walking. How to decrease pressure on stump? And the patient is right now using PTB socket.
Okay, so as I said that you have to see whether the discomfort is from which place. Is it really pressure causing discomfort or anything else? If it is pressure causing discomfort, pressure on a normal tissue, pressure on a abnormal tissue. What is the shape of the socket? What is the level of fibula? What is the status of any hypersensitive area like neuroma is there or not? The stump factor must be excluded first. Then comes about the prosthetic factor. If stump factors are excluded, then you can very well modify the prosthesis. Look for which side is the pressure side, and accordingly you can give clearance to that side. You can add ethaplex to that area to prevent pressure. And moreover, also if the patient is very much overweight, they can use a assisting device like walking aid, like in the form of a stick or a low cross to avoid that.
Thank you, sir. One more question is there from Dr. Abhishek Shanial, sir. What precaution we have to take for contralateral limb injury like sciatic nerve injury, sir?
Sciatic nerve injury?
What precaution we have to take for contralateral limb injury like sciatic nerve injury?
I didn't get, we are discussing PTB prosthesis, transtibial amputee. So most of the sciatic nerve supplies are gone, already cut.
Sir, the only sound side, sir.
Sound side, I think, sir.
Sound side is there injury on the sound side.
Yes, sir.
How do you manage?
What
No, sir.
precaution we
Sir
have
is
to do?
asking how we can avoid it. As in, if the patient is not having a proper gait, there are chances that he will be having some kind of sciatic injury chances there. So how we can avoid it like that?
So it's
Sir
like
might be
the
asking,
patient
sir.
is having a sciatic injury in the normal limb and the bilateral and the unilateral amputee on the other side. How it is taken care of?
So opposite side you have to give orthosis. I suppose the sciatic nerve injury is there. There's no problem. The bone and the muscle, it is weakness is there. So you have to support the limb other side with orthosis and opposite side the prosthesis. Or if if it's sciatic nerve injury, that means the whole below knee components parts are gone on the healthy side, and there you have to support the paralyzed limb or the weakened limb with orthosis and right side prosthesis. Besides that, anything can be done. Using sir also can add to that.
Apparently, he's asking how we can prevent the sciatic nerve injury. I don't think that the PTP socket would have any extension above the middle of the thigh. Even if we use a thigh corset, sciatic nerve will not get affected. So don't worry about it unless there is an additional injury which you have already covered.
He's
think-
asking that sciatic injury on the healthy side.
On the
Is
healthy
it so?
side, how can that be prevented? I mean, I don't think there is any correlation with the PTB prosthesis. Maybe with
Yes,
the
sir.
above knee prosthesis or with the hip disarticulation prosthesis, there can be a question of such a thing, but not with the PTB prosthesis.
Yes, sir. Saurabh, any other question?
Sir, one more question is there. In case of abducted socket, should the foot be in more lateral position?
No, if the socket is abducted, that means limb is going, it should be more medial position. Abducted means, stump abducted means is near the valgus or the knee joint. So you have to bring the center of gravity more medially. It is lateral place now.
Okay, sir. That's it, sir.
So if there is no more question, sir, using sir, can we wind up? You are the senior most member here. With
Please,
your teacher, our teachers. Sir, can we wind up here?
Thank you so much. We really enjoyed listening to you. Such a wonderful talk. Thank you.
Thank you very much, sir. And thank you all the participants who have joined this webinar. We are extremely thankful to you all. And I must give thanks to our IAPMR association and the PR team, those who are helping us publicizing this webinar, providing us a Zoom platform. I must thank to all the office bearers of the APMRO for constantly supporting this. And I must thank all my PG, my faculties for helping me for arranging this webinar. Thank you once again to all participants. Thank you all and good night.
Thank you, sir. Good night.